I like to start my lectures with a image that's not my title slide. So this is from the Moise Bison Range. Except you're in northwestern Montana and you like animals, it's a beautiful drive. Bunch of different types you can see. So this is a pronghorn antelope. I think they're just very beautiful. They're yellow and white and that, and they're very fast. So this is congenital anomalies of the GI tract and the obstruction and miscellaneous conditions of the esophagus. So there are me and Dr. Hughes' 2 websites for questions. The Twitter, which I promise I will start doing again. And then, like I said, I have a very strong interest in general pathology, organ pathology, and I have a strong interest in teaching medical students. I'm a forensic pathologist, so I don't get into the details of the pathologists know this material much better than me, which I hope helps me teach you. So please pause, look at this, read these, make sure they do not apply to you. These are 2 of my 3 disclaimers. If they do, don't watch the lecture. Here's the 3rd disclaimer. Once again, pause, read it, make sure it does not apply to you. And then when it does, don't watch the lecture. And then once again, there's my introductory presentation. If you're interested in knowing my teaching style, so not many people watched it, that's fine, I'm good with that. But just in case you want to know why I do things I do or stuff like that. Here are my references, all very good. I recommend each of these books. They're all very useful to me and that. And I wish some of them had been around when I was in medical school. So this time I actually have 3 questions. So if you pause for each question, we'll go through at the end. And remember, the idea of this is that you haven't had this material. And so when you read it, it's making you concentrate on this. And then when you go through the lecture, you concentrate on it again and try and find the answers. And they say it actually increases retention. So that's why I use this. So there's the first question. There's the second question. Pause. There's the third question. So there's 3 questions this time, but I thought they were all decent questions. So, okay, so we'll talk about congenital anomalies of the GI tract. So atresia is an absence of a segment of a GI tract. So you basically have a fibrous band. Means none. So fistula is an abnormal connection between 2 organs. So the common one talked about is a tracheoesophageal fistula. But with gallstones, you can actually have also between the bile duct and the duodenum. With colon cancer, you can develop enterocutaneous fistulas and things like that. So it's an abnormal connection, one that shouldn't be there. Stenosis is obviously narrowing of a segment of the bowel. Diaphragmatic hernia is where there's a defect in the diaphragm and allows herniation of some of the bowel contents up. We see this quite commonly at forensic autopsy, but it's traumatic. But I have seen it on several occasions where it has been a congenital lesion. Omphalocele and gastroschisis are both along the same lines. Basically, the gut does not return to the abdomen, so it's outside of the abdomen. In the omphalocele, the muscle fails to form, so you have this really thin sac. And then in gastroschisis, the whole abdominal wall fails to form, so you don't have anything between the outside and the surface of the GI tract. Ectopia is where you have normal tissue in an abnormal location, and a Meckel's diverticulum. The GI tract has several types of diverticula, both false and true. Meckel's diverticulums are true diverticulum, meaning all 3 layers of the GI tract, whereas the most common diverticulum, colonic diverticula, are false. They just have the mucosa and submucosa. So top left is a diaphragmatic hernia. So I tried to label this as best I can so you can appreciate it. So the lung you can see there, and right adjacent to it is the stomach. And then you can see where the diaphragm is. So basically this was a congenital hernia where there was a defect in the diaphragm and allowed the stomach to prolapse through that defect up by the lung. I've seen this associated with, sorry, I'm blanking. Maybe it'll come to me later. Marfan syndrome. It's seen associated with Marfan syndrome. I've seen a couple other times and things like that. So, and then the bottom right, this is atresia. So atresia, remember, A means none. So basically there's no GI tract there. So you can see the stomach and you can see where the duodenum is, and the red arrow shows a fibrous band. So there's no duodenum there. So there's no connection between the stomach and the duodenum. So that's atresia. And then that one's commonly associated with Down syndrome. To the top left, this is a tracheoesophageal fistula. So fistulas can be normally think about tracheoesophageal fistula, you probably think of infants, and you think of a congenital anomaly, which is common, but you can also see them acquired, and that's what happened here. The esophagus has been opened. You can see the region of the larynx, and the yellow arrow shows a black space. That's the fistula. So you can see the defect in the wall of the esophagus that leads into the larynx, the laryngeal region, the trachea. So this is an acquired tracheoesophageal fistula. The individual had pneumonia and eroded through and created that. So inflammation tends to stick stuff together and then can cause a defect in the wall, and you get connections that way. To the right of it, this is gastroschisis. So remember gastroschisis, the GI, like omphalocele, the GI tract doesn't return to the abdomen, so it's present outside the body. With an omphalocele, there's no muscle, but there is the rest of the abdominal wall, so you have a thin layer on the top of it. It's like it's in a sac. Whereas gastroschisis, none of the abdomen forms the abdominal wall, and so you see the organs. So there you can see the white arrow is the GI tract, the blue arrow is the stomach. The white arrow is the small intestine, the blue arrow is the stomach, and then you can see the liver in the background there. So ectopia. So this is in the proximal esophagus. So the first time I actually saw this, I thought it was intubation injury, and then somebody on Twitter explained to me that no, I think this is a salmon patch, and so I started looking more, and they were right, I was wrong. And so it's a salmon patch. You can see it's kind of the color of salmon. They're also called inlet patches, and it's basically ectopic gastric mucosa. So we're at the top of the esophagus, so we shouldn't see gastric mucosa there. To the bottom right of it is what it looks like microscopically. So you can see the esophageal mucosa there, the stratified squamous epithelium, and then you can see the glandular, and that represents the little salmon-colored patch, and that's ectopic gastric mucosa. Meckel's diverticulum, as I mentioned before, these are true diverticula, so they have all three layers of the bowel, versus the colonic diverticula, which are false and have the mucosa and submucosa but no muscularis wall. It's a remnant of the vitelline duct, and I've also seen omphalomesenteric, and that connects the yolk sac to the gut. And you usually see these in the region of the terminal ileum. So oftentimes they can be completely incidental. I see these at autopsy not infrequently. I've seen multiple in my career. And then occasionally they can have gastric or pancreatic tissue. And then if they have that, then there's a risk for ulceration or other conditions associated with it. But otherwise, it seems like they're usually pretty asymptomatic. So these are two examples of many Meckel's diverticulums I've seen. The top one, since it was still in situ, I decided to make sure. So the black arrows show the extent of it. And to the left of it, it looks a little bit solid, but there wasn't actually anything inside of it that was abnormal. And to the right of it, the yellow arrow shows the Meckel's diverticulum. The rest of it is the normal length of terminal ileum where it's at. Congenital pyloric stenosis. So this one can occur just incidentally, relatively common, 1 in 500 births, much more common male than female at 5 to 1. It is associated with other things, Turner syndrome, trisomy 18, erythromycin exposure. If you are interested in pediatrics at all, family medicine, autopsy actually, there's a book called Smith's Recognizable Patterns of Human Malformation. And it's fun to flip through and everything like that, but it's amazing. Some of these conditions that you learn, like duodenal atresia with Down syndrome. If you actually read Down syndrome in there, there's so many things associated with it. So it's kind of interesting to go through and see all the different ones. But anyway, just a little side thing there. So clinical history, so you get this stenosis of the pyloric region, which is going to be difficult to empty the stomach. So they get regurgitation and projectile vomiting by 3 weeks of age. You can feel a palpable mass. They can just go in and incise it and curative. So easily to treat, great characteristic clinical history. Hirschsprung's disease is also called congenital aganglionic megacolon, which is actually better because it's congenital. It's something you're born with. Aganglionic, so you don't have ganglion cells in the colon, and that leads to a dilated colon or a megacolon. So it's always nice when the name has the descriptions in it. What it is failure of neural crest cells to migrate into the colon. 1 in 5,000 births, and 10% of cases are in Down syndrome patients, so associated Down syndrome. Mutations are RET. And so what happens is if you don't have the ganglion cells, you don't have normal colon function, it becomes stenotic. And so it's obstructed and then proximal to the site of where the Hirschsprung's disease is, because it's not the whole colon, it's different lengths of it. And I remember when I was on pediatric pathology, they would remove colon, they'd remove a little more, they'd remove a little more until they found ganglion cells, and then they'd stop. But because you have that kind of more tight area because of the lack of innervation, then it's going to cause obstruction. Proximal to it, you're going to get dilation of the colon and hypertrophy in response to trying to probably get stuff through. And then you can get a markedly dilated colon or a megacolon, and that can lead to perforation. And then if you get perforation of the colon, you can get septic. So this is a pronghorn antelope. So a technique that I'm always trying to do with the camera that I learned is if you have a moving object and you keep the camera on it and you click, the object will be in focus, but the background won't be. And so I've had this work one time. This was not the one where it worked great, but it's something I'm always just trying to try and stuff like that. But I thought this one worked okay, so figure it's okay to show. Okay, obstruction of the esophagus. So some lesions that can lead to obstruction of the esophagus. Spasm can, if it just clenches down. Diverticula, Zenker's diverticulum are usually at the superior esophageal sphincter. Webs, Plummer-Vinson syndrome has webs. And that one, Plummer-Vinson syndrome, associated esophageal webs. IDA, iron deficiency anemia, also glossitis, inflammation of the tongue, chelosis with the lips. And then what this is it says it's a ledge-like protrusion that makes it a web. And the esophageal ring, common one is Schatzky's ring, is circumferential. So this came from Dr. Stern's book. What he does is he goes through, and I wish I would have had Dr. Stern's book when I was in medical school. It's a great book on, because it seems like medicine, you learn the disease process and the clinical features, and then the patient comes in and they give you their symptoms and you got to figure out the disease process. So it seems like we learn backwards to it. His book goes through major types of presenting signs and symptoms, and then discusses key points in determining what the ultimate lesion is. And I think it's a great background, and gives you a good background for building on everything like that. A great book. I highly recommend it. So anyway, this is from there. So with esophageal dysphagia, you can either have solid food only or solid and liquid food. And then from that, you go up to where, if it's solid food only, is it intermittent or is it persistent? So if it's intermittent, it says it's usually a Schatzky's ring. If it's for persistent and they get heartburn associated with it, it's probably a stricture. If it's persistent and solid food only, no heartburn, younger is probably eosinophilic esophagitis, older is probably a neoplasm. And then with those, because with solid food, it's kind of more, there's like a physiologic lesion, it seems like. Whereas with solid and liquid food, it's kind of more of a functioning. So solid and liquid food, if they have dysphagia for that, if it's intermittent and they have chest pain associated with it, it's probably a spasm. And you can imagine with a spasm, it could prevent the esophagus from functioning at all, so you can't follow solids or liquids, and it's only going to be intermittent. Whereas if it's persistent, if they have heartburn, that can be associated with scleroderma or just ineffective esophageal motility, and then if they have regurgitation, achalasia. So this was kind of a way to look at this. So some important features were, is it solid food or solid and liquid? Is it intermittent or is it persistent, and help you form that differential diagnosis? So you start from a symptom and you work your way down to specific diagnoses. And it's not, like I said, it's not absolute. I know there's always more to it, but I think at a medical student level, it gives you a great background to build upon later. So I think it's one. So I hope that's useful. Achalasia, this is basically a failure of the lower esophageal sphincter to relax. So you have increased esophageal tone, like where we talk about reflux, where it's relaxed, and you have decreased tone. This is the opposite, and so it's going to be difficult to get things by that. And so what happens is you can have a failure of neurons to induce relaxation or a loss of neurons. So either, number one, you just don't have the neurons to do the function that they should, or the neurons are there, but they just failure to induce that relaxation, so the distal esophagus is tight, so food doesn't pass, and it's solids and liquids. Chagas disease can do this, Down syndrome, infiltrative disorders, so sarcoidosis and amyloidosis, those are both ones where you can see infiltration through from the granulomas or the protein, and then diabetes can also do it as well. So these are just other esophageal disorders. Sorry, I tried to organize these lectures relatively by topic, but a couple things just didn't fit in when I was making it, so I just threw them in. Mallory-Weiss tears. These are longitudinal tears of the distal esophagus. You can see to the right of it, right at the GE junction, the yellow arrow shows a tear. And what happens is with prolonged vomiting, prior to vomiting, you have to have relaxation of the lower esophageal sphincter, which makes sense because to get stomach contents out, they're going to have to go back up through the esophagus, so you have to relax that sphincter. And what it says is when you prolong when you have prolonged vomiting, that relaxation fails. And so you're forcing the food up against it and it can tear. So these actually are usually not of significance. They actually can heal just fine. They're common college students, drinking, things like that. But there's a condition called Borhave syndrome, which is basically a rupture of the esophagus. And that obviously is a catastrophic and is an absolute emergency. Esophageal stricture. So with gastroesophageal reflux is possible. When you get that stomach acid up, the damage to it and everything like that. Radiation, ingestion of caustic agents can cause a stricturing of it. So the stomach is to the right, the normal esophagus is to the left, and this is an older specimen, so it's kind of that brown discolored, but I think it still shows it. And so you can see the narrowing and the kind of white discoloration at the yellow arrow. That's a stricture. So the esophagus was narrowed at that point. And then esophageal varices, we'll talk about these with cirrhosis as well too, but these are most commonly associated with cirrhosis with increased, with portal hypertension, increased pressure on the blood to get back through the liver. It takes alternate routes, so this can include through the esophageal veins. So normally when I open the esophagus, the autopsy at the G junction, I don't see any blood vessels, none. So if I start seeing blood vessels, they're prominent, and these are really prominent. Above the arrowhead on the yellow arrow, you can see a blue band. They actually tried to band it, but you can see all the other like worm-like discolorations. Those are all prominent esophageal varices. And so the problem with this is it can hemorrhage. And so in people with esophageal varices, commonly people with alcoholic cirrhosis, other forms of cirrhosis as well, they can die from a GI bleed. Okay, so first question, pause, then we'll go through it. So a 20-year-old male college student presents the emergency room on Sunday afternoon, complaining that he has vomited up blood and is very concerned. Further questioning indicates that he was drinking with friends heavily the day before and had vomited much of the morning. Other than the bleeding, he is essentially asymptomatic. Of the following was the most likely diagnosis. So we just went through this. So this would be the Mallory-Weiss laceration. So prolonged vomiting makes it so the lower esophageal sphincter basically gets tired and doesn't relax the way it should. And then you get tearing. But usually they have bleeding, but they're usually otherwise easily survivable. Okay, so pause, read it, then we'll go through it. So a 27-year-old male presents to an acute care clinic complaining that over the past year he has slowly developed a greater and greater difficulty swallowing food. He has no significant past medical history and does not smoke nor use alcohol excessively. Because of his difficulty with eating, he has lost about 10 pounds in that time frame. Upon further questioning, the patient indicates that he has difficulty swallowing both solid as well as liquid. He does not have chest pain associated with dysphagia. Of the following is the most likely diagnosis. So acute esophageal spasm would be solid and liquid, but it's intermittent. So it's not that one because he's having this, it's not intermittent. Schatzky's ring is solid. Plummer-Vinson syndrome is esophageal webs, the ledge, so that's solid. Achalasia is solid and liquid, and esophageal adenocarcinoma is usually solid. So of the choices up there, the best one is achalasia. Pause, look at it, and we'll go through. While performing an autopsy on a 24-year-old male who died as a result of a gunshot wound, a forensic pathologist identifies a blind-ended outpouching of the small intestinal wall in the distal ileum. Of the following from which this anomaly originates, so this is a Meckel's diverticulum, so that's from the vitelline duct. Okay. So once again, use reflection, go back through, think about what you just heard, come up with, I hope, 5 important points. I hope I made 5 important points. And this is a good way to kind of cement this information in your mind and help with retention. And then here's another one. Sorry, my theme was pronghorns at Moise on these pictures. This one I just thought was kind of neat. I hope this lecture has been useful to you. Thank you.